Welcome, and thank you for having me. This will be a lot different than these other talks. I'm not a research scientist, I'm a clinician, so I'll be showing you an entirely different way of looking at things. But I wanted to really start by looking at ADHD. I mean, a lot of this is focused on what food dyes may or may not be doing to kids with ADHD. And having seen thousands of them in my practice, I have my own opinions. But I think most of you know that there's a lot of ADHD out there, but maybe you haven't seen some of the data. This is the ADHD prevalence. As you can see, psychostimulant ADHD is just growing and growing. It's over 6 million kids the last time we looked, and about over half of those are taking psychostimulant medicines on a long-term basis. This is the growth of psychostimulants in the United States. 3,330,000 children approximately taking things like Ritalin, Dexedrine, et cetera, et cetera, et cetera. So it's a huge problem. Look at the growth between 1970 and 2012. In 1970, it was a minor problem confined to a very small set of very, very hyperactive kids. Now, it's just everywhere. Almost 20% of boys in high school have received the diagnosis of ADHD. That's kind of mind-blowing to me. And an interesting thing, I'll talk a little bit about socioeconomic variables. The amount of Medicaid patients who get this diagnosis is 33% higher in general. So we're encountering some things that have to do with socioeconomic status and ethnicity. This is an example of how completely unbiological the diagnosis of ADHD is. As you can see, the black is where there's the most ADHD, and as it gets lighter, there's less. And yet there's states right next to each other that have vastly different amounts of ADHD. And there's just no biological reason for this. Why should Indiana, for instance, and Illinois be so different, or Rhode Island and Massachusetts? This is all about many social and cultural factors. Factors is a wonderful book called The ADHD Explosion, which points out that wherever teach to the test is important, where teachers and principals' jobs are on the line when kids don't do well, the rate of ADHD diagnosis and Ritalin use goes way up. Well, why? Because they work to a certain extent, and because if you have a problem kid who's going to drag down your grades, it helps to put them on medication, and that's our reality. Where in the Bay Area, we have a lot of schools down in Silicon Valley or Marin, where the use is also extremely high because of the competition to get into Stanford and Harvard. And if the kid next to your son's taking Ritalin and doing a little bit better, well, maybe your son has ADHD and needs to take Ritalin. So we have these classes with incredibly high percentages of kids taking these medicines. So what's really going on? Are there more kids with ADHD than there used to be, or are we just diagnosing it more? So there's 4 possible explanations. One is that there are always this many kids with ADHD and we just miss them. Another one is we've loosened the definition. Another one is we're just misdiagnosing people for a variety of reasons. And then there's more people who actually have ADHD. And I think the reason for this great increase in diagnosis is all of these things to various extent. Now, I was really glad to hear somebody point this out during the first session that I was here right before lunch. ADHD, the symptoms of ADHD exist on a continuum. So the definition of ADHD, by the way, from the DSM-3 is some combination of hyperactivity, impulsivity, and/or inattention that causes impact in 2 areas of life. And for kids, that's almost school and home. So it's really a clinical diagnosis. And what's impact varies a great deal on who's looking and what school you go to and what your parents are like. But why I wanted to show this is that, say, if you take activity, well, there's a real big range of normal, right? I mean, some people are really quiet and some people are pretty active and all that's just normal. Same thing about focus. Some people are just naturally really, really focused people, and some people are not so naturally focused, but they do fine. But I also think there's a risk group. I think there's people over in this area who would do fine, except something throws them over. And that something that throws them over can be childhood traumatic experience that we call ACEs, adverse childhood experiences. It can be poor nutrition. Maybe in some kids it's food dyes. Maybe in some kids it's school situation. So these kids in the risk group really are kids who could actually fit the diagnosis, the definition of ADHD in response to a set of factors that we're trying to figure out. Okay, so we're better at finding kids. Yeah, I think we are. I think there's a lot of kids 30 or 40 years ago who we just thought were stupid, or they're bad kids, and we just pretty much forgot about them, kept them on passing through the grades, and then they dropped out of school. They were the class clowns, maybe. And it's good that we're finding them, diagnosing them, and trying to help. 2, we've loosened the definition. This is really true. Any pediatrician who's been doing this for a while will tell you that 25 years ago, the kid who you diagnosed with ADHD was the kid who came running into your office and tearing the place up, right? Jumping up and down, tearing through your drawers. I mean, you knew this kid had ADHD in about 10 seconds, right? This is not the kid who's being diagnosed with ADHD now for the most part. This other 90% are kids who sit quietly in your office. They look like anybody else, and they just have more subtle symptoms. Now we're diagnosing preschool kids, 3 to 5-year-olds who, quote, can't sit still, which to me is sort of absurd. I mean, I get this complaint. The teacher says my 3-year-old won't sit still for story time. Does she have ADHD? Story time, sitting still? I mean, who said a 3-year-old should be able to sit still for story time? Likewise, kindergartners now who can't read, who won't sit and focus on academics, they're brought to me because maybe they have ADHD. Well, a lot of kids can focus on academics when they're in kindergarten, but that's not what kindergarten was meant for. When I was in kindergarten, there were 3 requirements: eat, sleep, play. That was it. That was all you had to do. You know, now in San Francisco, you got to get a test to get into half the kindergartens there. It's ugly. But anyway, a lot of these kids are getting diagnosed at age 5, 5.5, because they don't like focus on their academic work when it's they're just not really ready. I think we're misdiagnosing many kids. Kids are sent by the teachers or schools or worried parents, and nobody has time to take the time to really do a good history and exam. There's a lot of academic pressure, especially as you get into high school and college kids. And let's face it, we are a pharmaceutical society. If there's a pill that can solve a problem, we're likely to go looking for it. There's lots of stuff that can be misdiagnosed as ADHD. This is just a quick list. I won't dwell on it. But for instance, learning disabilities is not ADHD. And learning disabilities can look a lot like ADHD, because kids who are having trouble, say, learning to read can kind of give up, and then they'll start fooling around, and next thing you know, they have an ADHD diagnosis when that's really not the problem. Kids who've been abused of sexual or physical violence, and sometimes just kind of hard kids, you know. Sleep is major. Kids who have sleep apnea can look like they have ADHD. This is a great study. So it turns out that if you're born in August rather than September, you're twice as likely to be diagnosed with ADHD and twice as likely to be treated with medication. Why is that? Because you're the youngest kid in the class. That's when the date is. So instead of going into kindergarten at almost 6, you're going into kindergarten at just 5, and you're much more likely to be diagnosed. This study was replicated in Canada. Even in Iceland, the whole youngest third of the class, 4 months, were more likely to be diagnosed with ADHD and prescribed stimulants. So we're just not really doing a good job at figuring out who's just developmentally a little younger and who really has ADHD. ADHD evaluation. History, history, history. There's no test, no MRI, no CT scan, no computerized test that can actually make the diagnosis on its own at this point. So it just takes some time, and that's time that a lot of doctors don't have right now. because there's not enough developmental doctors and specialists to diagnose all these kids who are brought in for the problem of ADHD. So it gets up to general pediatricians who might have 20 minutes to kind of make this kind of decision, which is just not enough. So could more kids have ADHD? And by that, remember, I'm thinking of these risk kids who maybe wouldn't have it, but then some environmental thing pushes them over. So environmental toxins, the amount of screen time, poor nutrition, which I'll talk about a little more, and stressed parents with little time, all those things could combine to make that happen. Electronics, I mean, you all know this problem. It's hard to even know what to say about it because it just gets worse all the time. The amount of time kids are spending on one screen or another. And we don't really have the research that tells us exactly what this is doing. It seems like it doesn't do much for their attention span. And I'll tell you that I have parents in my practice who say that the slightest bit of screen time for their kids throws them off for the whole day. It's a big fight among almost all families that I see. But we don't really have a good research on it. But we do have some research indicating that television watching hours, this was when television was the big thing, was associated with a higher incidence of worsening of ADHD. So maybe it's no surprise that with toxin exposure, screen time, poor nutrition, and a highly overstressed society that more kids really do fit into the criteria for ADHD. So the next question is, do all these kids need psychostimulants, right? I mean, that's what we do for ADHD as a general rule, psychostimulants, Ritalin, Adderall, et cetera, et cetera. And why not use stimulants when they work, right? Well, first of all, I want to preface this by saying I'm not against medication. I have many kids in my practice who have to take medication. I think it's overused, and I think it's good to start with non-medication alternatives when you can, but I'm not somebody who's opposed to the use of medication. Sometimes you just need them. They are effective, usually in the short term, and they can significantly improve performance. But the interesting thing is there's no long-term studies that really evaluate adequately the effect of these drugs on a developing brain. Remember, these kids, you give it to them when they're 6 or 7, are very likely to be taking them until they're 18. And that's the time of greatest brain development. And when you affect neurotransmitters, as you do when you give these medicines, you're going to affect brain development. And we don't know whether it's affecting it in a good or a bad way, really. Another way to put that would be, if you take these medications for 12 years, when you're 18, are you more or less likely to have an ADHD brain? And we don't know the answer to that. Is it suppressing some kind of development that may counter ADHD, or is it encouraging some kind of development that will decrease ADHD? These are some of the short-term side effects, and a lot of kids have them. Most don't. Most are okay, most are mild, but they can be really bad. Just last week, I had a child who started taking, I think it was Concerta, a Ritalin derivative, and he started thinking everybody on the bus was going to kill him. And this was in just a few days. And it took a little bit after they stopped the medicine for this kid to calm down. It's probably like 1 to 3% have this kind of stuff going on, but when you're looking at 6 million kids, 1 to 3% isn't really that small a number. 60 to 180,000. Right? There's a lot of more subtle effects that happen with these medications. This chestnut himself, lost her spark, joy. The kids themselves will tell you they feel bored, or they're not having as much fun. They're not, they can't really put their finger on it, but something is wrong. They don't like it. And then the other kids are really happy taking it. They're doing better, they're more successful, they're getting more praise, and they don't have the side effects, so you just have to look. But these are things we do watch for. So here's a question: do they prove long-term outcome? The biggest study ever done to see if they could look at that was called the MTA, and they looked at 579 children. They divided them into 4 groups: medicine plus a behavioral intervention, just behavioral, or whatever happened out in the community. And at 14 months, it looked like, whoa, each medication group, the 2 groups of medication were better than anybody else. And people thought, okay, that's the answer. Medication works fairly long term. Well, they stopped the randomized part and they followed these kids. And at 24 months, only 50% of the difference remained. And at 36 months, it was gone. In other words, there was no difference between kids taking medicine and not taking medicine in 36 months. And nobody's really sure about why that is. It seems kind of counterintuitive that it would work for this long. Did the kids get sort of used to the medicine, where the medicine's not increased as much as they needed to be? It's other things go on. It's really not clear. One thing the author says is that all these kids improved. So that might have washed out some of the effect of the medication. And I think that's really true, because if you look at untreated kids who are diagnosed with ADHD around 7 or 8, 30 to 50% of them, depending on the study, don't have ADHD at age 18. So we're treating a lot of kids assuming that they're always going to have ADHD, but they may not. And this may be what's going on with this study. The Cochrane review, which is the most really hard-nosed, evidence-based review of anything in medicine, just looked at this in 2015, and they said, we can't say whether Ritalin actually improves the lives of kids with ADHD based on the evidence, which was really surprising from the Cochrane review. And it said it highlighted the urgent need for large RCTs of non-pharmacological treatments. So what does an integrative approach to ADHD look like? What if you weren't going to start with medicine? In integrative medicine, we really try and look at a whole child, not just some child who has a set of characteristics that are difficult, but what's going on with their personality, their family, their community, their school. And sometimes changing the home environment or the school is a better intervention and more useful than anything else I can do, any herbs or diet or anything. One thing I run into in the Bay Area is a lot of these kids are in super competitive schools, and they shouldn't be. They should be in a normal school. But their parents have they're highly successful people with high drives, and kids who have ADHD, education is tough on them. Sitting in the school for 6 hours is tough on them. So why make it harder and put them in a super competitive school? So I look at nutrition, food sensitivities, elimination diets, some nutritional supplements. I'm not going to go over all of this with you because there's definitely not time, but I'm going to go over a little bit. Sleep is really important. A lot of kids with ADHD just don't sleep well, and if they sleep better, they actually perform better. And the other thing that's going on now is these kids are taking their phones and their screens into bed, and the parents don't know it. And parents and they're texting each other or Instagramming each other until 2 in the morning, and then they're getting up at 7 to go to school, right? And this is obviously not good. So I have a lot of parents in my practice who are literally confiscating the screens when the kids go to bed. Because, you've all done it. Back in our day, it was reading, with a flashlight, but it's the same thing, right? Let's get to diet, though. So this is getting close to what this conference is about. So this is about the effect of an elimination diet on ADHD. So what they did is they took 100 kids and they put 50 of them on a very restrictive diet. And you can see it was just rice, meat, vegetables, pears, and water. That was it. And they were on that for 5 weeks. And then they looked at their ADHD rating scales. And they had a 40% improvement, 64% of them did. That's enormous. That's what you expect if you give somebody a Ritalin-like compound. Now, this was an open label trial in the sense that clearly the parents and the kids both knew that they were getting this diet, or they're getting the regular diet. But the assessor was blinded. Who was looking at these kids was blinded. And the teachers and doctors who work with the children saw really big changes in their behavior. In fact, the study author says they were flabbergasted. They really didn't think anything was going to happen. And I see this in my kids all the time. I use elimination diets for kids, especially the hyperactive kind of kids. And probably about a third of them have really significantly positive reactions and end up not being able to have gluten or dairy or eggs or something. There's some food that triggers them. Now, it's a lot, a third is only a third. And there's a lot of kids who don't. But if that's the problem, it's really worth looking at. Now, being scientists, you might say that Well, this is just one study, but they've actually been doing this study since the 1970s. And I think Dr. Ning is going to go through all these studies tomorrow, so I won't dwell on it. But these studies really do uniformly show an improvement with an elimination diet. And one of the things that was in all the studies that was the most difficult for the kids were food dyes. Gluten, dairy, food dyes were usually the three things that were the biggest part of it. And I'm not a scientist to evaluate the evidence. I can tell you that many, many parents in my practice tell me when their kid gets either red or yellow, they go crazy. I mean, they're not just a little hyper, they go crazy. Now, that's maybe a small percentage of kids. It may be 1% of all kids, it may be 10%, 20% of kids with ADHD. And that's the problem with this kind of, population-based way of looking at things, is that there's a certain proportion of kids who really, really react badly. I think you knew about this in Europe. There is a warning label and we don't have it. This is some of the, we just went over this, so I won't dwell on it. But what I did want to say is, whose children are eating these things? I have a very interesting practice. I mean, a good section of my practice is from Silicon Valley and Marin, with very well-educated and very rich people who never give these kids this stuff. These kids eat sushi and seaweed on a regular basis. I also have 25% or so of my patients are on Medi-Cal, and they're from the poorest sections of San Francisco or other places. And they're the kids who are eating an enormous amount of this stuff. Their kids are getting up and drinking sodas in the morning. They're eating Lucky Charms and vitamins with artificial colors and flavors, and they're drinking Gatorade, and they're eating, hot Cheez-Its. And the parents literally don't know that that's a problem. So when we're looking at these population statistics and we're saying, well, what's the average consumption? We really need to look and say, what's the average consumption in certain groups of people? Because it could be, these food dyes could be hurting the people most vulnerable. They're going to the worst schools. They have the least time for their parents. They probably have the worst diets altogether. They probably live in a food desert where it's really hard to get healthy food. There's few grocery stores and lots of little tiny stores with bad food in them. So this could be a major problem for certain sections of our society, and not when you look at the overall picture. Again, look at the continuum, look at those risk people. Those are the ones who having food dyes or having gluten or something else may really throw them over. In fact, one time I did a telephone interview for a newspaper, and I said that there was a difference. These kids over here on this side could probably eat anything. I said they could probably eat 5 Pop-Tarts for breakfast and still not be hyperactive. And that was like the only thing they quoted me about out of this 20-minute interview is Dr. Newmark says some kids can eat 5 Pop-Tarts for breakfast. Right? But in a funny way, that's probably not true, but it is true. Many kids, it doesn't matter, in my experience. So basic nutrition, or when did Pop-Tarts become breakfast? Nutrition, I find, is really, really important, especially processed carbs and the glycemic index. If kids can get protein, some fat and fiber, and not so much processed carbs for breakfast, they'll do better. Because what happens is that those processed carbs, along with the sugar they eat, it increases your blood sugar really quickly, which causes insulin to be produced, which drops your blood sugar below normal, and now you're hypoglycemic, and you're irritable, and you can't sit still, and you're not focusing. And that is what happens to some of these kids. And think about some of the breakfasts. I mean, forget even Pop-Tarts. What about frozen waffles with syrup? Frozen waffles with syrup is taking a highly, highly processed carb, which turns into sugar in your body immediately, and adding some sugar to it. You might as well take 12 tablespoons of sugar and pour it down your child's throat with a funnel and send them off to school. Now, this kind of breakfast is fine for the weekends if you want to do it, but not good for kids with ADHD and who are going to school. This study just shows that kids who were given a low glycemic index breakfast, these are just regular kids, not even kids with ADHD did better on cognitive tests, executive function, working memory, and attention a couple of hours later. So nutrition is really important. This is a story, not a study, but it's pretty interesting. There was this place called Appleton Central High School, which was a school for really, really difficult kids, as you can see from the slide. They were struggling. They were disruptive, truant, psychological and emotional problems, bad home environments, and it was a real difficult place. And what the school did is they did one intervention. They took the junk out of the vending machines, and they brought in an outfit to supply healthful breakfast and lunch to these kids. And it was a good experiment because these kids all ate breakfast there. And the result of just that was tremendous. I can say without hesitation, it's changing my job as a principal. Read what she says. It's 0 weapons, 0 expulsions, 0 premature deaths. Can you imagine what was going on in the school? If this was like really what was an impressive change for her? Even the teachers, I've noticed an enormous difference in the kids in my classroom, simply from eating normally. And this wasn't some kind of, brown rice and vegetable kind of diet that the kids did not want to eat. They had sandwiches and they had eggs and they had pretty good food. On one of my longer talks, I have the menu. But the point was it was healthy. It didn't have lots of sugar. It had plenty of protein. It didn't have food dyes. It didn't have preservatives. And the kids just did a lot better. So I want to tell you about just one intervention out of the many that I use because it's the most evidence-based. One of the things we know is that fish oil in the form of omega-3 fatty acids in the form of fish oil can really help ADHD. We know that kids with ADHD have lower levels of omega-3s in their blood. Omega-3s, for some of you might not know, are really, really important for brain function. It's the kind of fat that lines the neurons of your brain. And if you don't have, and it makes things move in a fluid way, and if you don't have them lining your brain, you have omega-6s, which are stiffer, and so things don't work as well. So they have decreased levels of omega-3s, and we know that omega-3 supplementation increases these levels. This is also true in autism, by the way. But do they actually help ADHD? Well, there's been more studies about this than in any sort of non-pharmaceutical ADHD area. And in this meta-analysis, and there's been more than one, omega-3s were found to be about 40% as effective as stimulants. That's pretty good for something that's non-toxic, does not have negative effects, hardly has any side effects, is cheap and easy to get. So omega-3s are just one of the things that I look at. Other things are iron levels can be important in ADHD, especially serum ferritin, a lot of studies on that. Zinc, the same way, vitamin D. And then there's one or two botanicals, herbal things that might be good for ADHD, but the studies are pretty preliminary. Ginkgo, ashwagandha, gotukula, some Indian herbs. And then just looking at parenting can be really, really important. Parents have a lot of trouble with many of these kids. Sleep and school interventions obviously are really important. I have a lot of kids in my practice who their story is first grade was horrible, second grade was really good, third grade was bad, fourth grade was good. Why is that? It's the same kid, different teacher. And it's not even bad versus good teachers. I mean, I have great respect for all of them, but it's that fit. And it's whether the teacher was willing to accommodate some of the differences in learning styles and behavior. So anyway, my take-home message is be careful not to overdiagnose it. Also, we should try and prevent the social and economic conditions that are causing it to happen. And I also think that before we start with pharmaceuticals, we could look at some of the more safe non-pharmaceutical options. Thank you very much.